Hey everyone, and welcome to this definitive explainer on musculoskeletal coding. I am absolutely thrilled to have you here today. As an orthopedic surgical coding educator, my goal is to give you way more than just a boring list of codes to memorize. We are going to build a rock-solid clinical framework together. We'll be moving logically from the least invasive joint procedures all the way up to the most definitive joint-altering surgeries. Because if you truly want to master musculoskeletal coding, you've got to understand the anatomy, the surgical approach, and those incredibly strict compliance rules that govern the whole shebang. Okay, let's dive right in.
Here's our quick roadmap for today's session. We'll start with an overview of joint procedures, move into arthrocentesis and joint injections, tackle arthrotomy coding guidelines, break down arthroscopy and NCCI rules, cover arthrodesis principles, and finally wrap up with HCPCS contrast codes and our final summary.
All right, Section 1, Overview of Joint Procedures.
Now, to code accurately, you absolutely must know the territory. Think of the joint cavity like a highly specialized, sealed environment. You have the articular cartilage protecting the bone ends, and that is completely enveloped by the articular capsule and the synovial membrane, which holds all the synovial fluid. So whether a surgeon is simply introducing a tiny needle to aspirate some fluid, or they're making a full-blown incision, knowing exactly which anatomical space is being breached is literally the foundation of accurate MSK coding. Everything we talk about today revolves around this very precise biological space.
Moving on to Section 2, Arthrocentesis and Joint Injections.
Let's start with the least invasive interventions. Procedure codes for these injections are primarily classified by two major factors: whether or not ultrasound guidance was used and the anatomical size of the joint. You have to categorize the joint correctly to land in the right code family. Small joints, those are your fingers and toes. Intermediate joints encompass the wrist, the elbow, and the TMJ. And finally, major joints. These are your big weight-bearing or high-mobility centers, like the shoulder, the knee, and the hip. Memorize this classification, folks, because it is your starting point for literally every single injection scenario.
So why do we even perform these procedures? Well, the clinical indications usually range from therapeutic to diagnostic. On the therapeutic side, you're looking at things like an intra-articular injection of a corticosteroid to calm down inflammation, or maybe treating a locked jaw at the TMJ. On the diagnostic side, the provider might be aspirating fluid to test for a suspected septic arthritis, or they might be draining a really painful hemarthrosis, which, if you're wondering, is just a buildup of blood in the joint space right after a trauma.
Let's actually anchor these guidelines with a real-world case study. Imagine we have a patient presenting with unilateral osteoarthritis of the right knee. The plan? A therapeutic right knee injection using Synvisc. Reading through the documentation, we see that landmarks were identified using fluoroscopic guidance, the surgeon chose a medial approach, vascular uptake was ruled out using Omnipac dye, and finally, 2 milliliters of Synvisc were injected right into the target site.
Okay, so what's the verdict? Looking closely at that documentation, we can extract our codes. Because this is a major joint, the knee, and the primary guidance was an ultrasound, we land cleanly on CPT code 2610. But wait, we can't stop there. Crucially, we have to append the -RT modifier to specify the right knee, ensuring lateral specificity. For the diagnosis, that unilateral right knee osteoarthritis points us directly and precisely to ICD-10 code M17.11. Nailing this accuracy is exactly what ensures proper reimbursement and clean claims.
Section 3, Arthrotomy Coding Guidelines.
Now we're escalating the level of surgical intervention and moving into open joint procedures. An arthrotomy requires a direct open surgical approach right into the joint capsule. The surgeon uses retractors to literally hold back the tissue, exposing all those internal structures directly to their naked eye. As you can imagine, this makes it significantly more invasive than the needle-based injections we just looked at, and the coding weight absolutely reflects that increased complexity and risk.
When you're coding arthrotomies, keep in mind the scope generally includes exploration, drainage, or the removal of a foreign body, and this is inclusive whether a biopsy is performed or not. You really have to play detective and look for the specific joint procedures documented in the operative report. For instance, is it an excision of torn cartilage in the acromioclavicular joint? Maybe a capsular release in the elbow, or a TFCC repair in the distal radio-ulnar joint. Now let's talk about the knee, because this is a massive trap for coders. You absolutely must differentiate in the documentation whether the semilunar cartilage excision was medial or lateral versus medial and lateral. That single conjunction, and versus or, completely changes your code selection.
Section 4, Arthroscopy and NCCI Rules.
All right, transitioning into moderately invasive, highly technological territory,
Arthroscopy. This is where the surgeon meticulously visualizes and treats the joint space from the inside out. They use a lighted camera, the arthroscope, alongside some incredibly specialized irrigating and trimming instruments, all inserted through tiny little keyhole incisions called portals. It's a really elegant procedure, but let me warn you, its coding rules are notoriously strict.
If you remember nothing else from this explainer today, I want you to tattoo this paramount compliance rule on your brain. Surgical arthroscopy always includes diagnostic arthroscopy. You must never, ever unbundle a diagnostic scope code if a surgical arthroscopy is ultimately performed in that same joint during the same session. The diagnostic lookaround is already inherently built right into the value of the surgical repair. No exceptions.
Well, okay, coding is never entirely without its nuances and exceptions, right? For instance, what happens if a surgeon starts out with an arthroscopy, but then has to open the joint, converting it to an arthrotomy? When open and endoscopic procedures happen concurrently like that, you append modifier 51 to indicate multiple procedures. Then there's the famous loose body or foreign body exception. You can only separately code for an arthroscopic foreign body removal if the documentation explicitly proves that the object's diameter was literally larger than the arthroscopy cannula itself, which means the surgeon had to enlarge the portal or use specialized retrieval maneuvers.
Beyond those strict bundling rules, surgical arthroscopy codes are further broken down by the specific type and extent of the intervention. Again, you've got to read that op report like a detective. Was it performed with or without a synovial biopsy? Was the synovectomy just partial, or was it complete? Did the surgeon perform a limited debridement, or did things escalate to an extensive debridement? Other common classifications include the lavage and drainage of an infected joint, or adhesiolysis to break up tough restrictive scar tissue. The exact terminology the surgeon uses is exactly what dictates your final code.
Section 5. Arthrodesis Principles.
So, what happens when we reach the highest level of intervention? We get to arthrodesis, which is essentially the surgical fusion of a joint. When joint pathology, think advanced bone-on-bone osteoarthritis or severe instability, becomes utterly untreatable by lesser means like injections or arthroscopy, the surgeon steps in with a definitive solution. They perform an arthrodesis, intentionally and permanently eliminating mobility at that specific joint. It can be an extremity, like a wrist fusion, or even a complex spine arthrodesis categorized strictly by the surgical approach. The trade-off for the patient is profound. They sacrifice flexibility, but in return, the procedure eradicates their severe, debilitating chronic pain. It's a major structural alteration.
Finally, Section 6, HCPCS contrast, and our final summary.
Let's wrap up our framework by looking at the often overlooked but financially vital HCPCS Level 2 codes. If a provider performs an arthrography to evaluate joint structures and injects a water-soluble iodine contrast, you need to report HCPCS code S0259. For a CT scan utilizing IsoView or iopamidol, you're looking at Q9966 or Q9967. If it's an MRI scan using gadolinium, you'll select from the A9575 to A9585 range. And remember those therapeutic intra-articular injections we discussed earlier? If a specific corticosteroid like triamcinolone acetonide is used, you absolutely must capture that medication cost with a code like J3301. Matching the exact drug or contrast agent to the procedure is an absolute must.
And that brings us to the end of our journey through the joint. By truly understanding the clinical escalation from simple needle injections all the way up to complex joint fusions like arthrodesis, and by deeply respecting strict rules like NCCI bundling, you now possess a rock-solid logical framework for therapeutic joint coding. Now, while we didn't touch on the massive complexities of arthropathies today, like unicompartmental knee replacements, hip grafts, or total shoulder reconstruction, the fundamental coding logic remains exactly the same. Just ask yourself this the next time you look at an operative report. If the surgeon changes the approach, how does it fundamentally change my code? Keep asking those clinical questions. Like, share, subscribe to Decode Healthcare with Harshal.